Yes, thank you very much for the introduction. In the next 25 minutes, I will talk about MR Neurography and what I think is up to date for the clinical routine. So these are my financial disclosures. And this is the structure of the next 25 minutes. I will talk about MR Neurography and diffusion tensor imaging, and then we will look at some cases which give you an impression about what you can achieve these days if you tailor your protocols. Well, first about some questions to the audience. Who in the room is actually doing MR Neurography on a clinical basis? Raise your hands, please. Okay. So those who raised their hand right now, can you make a diagnosis on this case, please? CIDP, perfect, yes. So there are a couple of people here who actually just got the case right here. So this is actually a MR Neurography study of chronic inflammatory demyelinating polyneuropathy. It's an inflammatory disease. You can see there is a big enlargement of the nerves at the cervical plexus here on the right-hand side, but also on the left-hand side. And then you see a couple of sagittal images. I basically like stir images in the sagittal direction. And here you can see these huge enlarged nerves all around here. So a pretty easy diagnosis if you have good images, and I will show you how you can get to such kind of images. In my clinical routine, I offer MR Neurography on a daily basis. This is actually what we have. We have C-spine and cervical plexus protocols, shoulder, all nerves around the upper arm and elbow, lower arm. So we cover basically the whole anatomy from proximal to distal. And the numbers of exams exponentially rise if you do this, if you're offering this in your clinical routine. At the moment, it makes up to 20% of our daily MSK business. Well, for didactic purposes, I always show this slide here, and I like to distinguish between these two types of imaging portions. First is anatomic nerve-selective imaging, and the second is anatomic nerve-selective imaging. This is actually in a red box, because I personally think that the red box can be applied by everybody in this room. Then we have this yellow box here, which is functional nerve-selective imaging, and that's basically DTI. And I will come to this later. I think DTI is an emerging technique and can be used these days already clinically in dedicated centers. Well, start with this red box, anatomic non-selective imaging. What does this mean? Well, basically look on this image here. This is a lower leg of a patient who had an amputation here. And then you can see there's a nerve coming down, the tibial nerve, and at the end of the nerve we have a neuroma. So it is identifiable, this lesion here. But what you also see is that we have a lot of tissue overlay. We see joint fluid, lymph nodes, vascular signal, mainly from small veins around here. And even the small vessels in the muscles are somewhat bright. So this is a non-selective image. It is a high-resolution image. You can see it's a 3D data set acquired with a pretty high resolution, 1 millimeter in all three planes. And we have a superior T2 contrast. But anyway, so this is non-selective. We see a lot of other structures as well. How can you apply or actually get these images? Well, you can use the current sequences which are available on the different platforms. For example, Space on Siemens, Vista on Philips, or Cube on the GE platform. So these are regular sequences applicable to in a daily routine business. Let's move on to the next red box, anatomic nerve-selective imaging. Well, here you can see what does this mean. That's the exactly same case. You see the lower leg here, amputation, and on the right side you see the selective image. You can see that we have a good suppression of the joint fluid, of these lymph nodes here in the popliteal region, and also of these small vessels here. What you now see selectively is the nerve, which is coming down, and then you see the neuroma at the end of this nerve. So just what we try to do here is a little bit similar to what we do in MR angiography. We suppress the background signal to get an isolated view on the structure of desire, and this is, in this case, of course, the peripheral nerve system. So how can you achieve that? Well, actually, you can also employ current sequences which are on your scanners. For example, if you work with the Siemens platform, you will find somewhere in the sequence tree the PSIF sequence. It comes with as a 3D sequence, and it actually allows you to switch on gradients so that you have a slight diffusion weighting in this sequence, and this actually suppresses your background signal. I find it quite helpful to have a B-value around 80, and with this you can get such nerve-selective images. Most of the scanner vendors are actually working on new sequences. And like 3-4 years ago, this new type of sequence was presented by a group from Japan. Here you can see the original publication. It was called at that time a 3D Shinkai. Very complicated term, but what it does is actually it has a nice fat suppression using a spare pulse. It has a good vessel suppression using this new technique, which is called IMSDE. I'm not a physicist. There are a lot of physicists around. They can explain you what it is, actually. But it works pretty nicely. You can see the vascular system is suppressed. And the whole thing is that it is a contrast-efficient T2-weighted 3D rare sequence, which employs variable flip angle technique. So at the end, you get these nice images. This is taken from this original publication. And then when you go to the vendor, it's at the moment sold by the Philips company. Then they renamed it. It's now called 3D NerveView. It's much more easier for marketing purposes. At least these marketing images look quite nice. So you have good suppression of all these things, and you have an isolation of the peripheral nerve system. So if you do not use Philips, or if you're not so rich that you can actually buy this sequence because it's quite expensive, then you can self-made your sequences. So this is taken from the Siemens platform. You see, we employed a T2-weighted spare space sequence. It's a 3D sequence. We applied a stir pulse to get this fat suppression right. And then we actually opened up these parameter cards, and then unfortunately this is in German, but you will find a tab which is called contrast, and in this contrast tab you will find one which is called general, and then the third level you go to this blood suppression tab, and when you open this tab up, then you can actually switch on gradients in all 3 directions. And if you do a little bit of weighting, like 100 millitesla in all 3 directions, then you will have an isolated view on the peripheral nerve system, because it actually does quite similar things like this 3D NerveView sequence from Philips. It suppresses you the vessel system, and the fat is nicely suppressed as well. So you can self-made images like that, and this is actually done on a regular Skyra scanner. So this is a technique which you can reach all yourself at home, and I think it's not far away from clinical application because it's a real picture. So how do you approach these images when you have actually acquired them? Well, first of all, you need to know the anatomy, and as the other speakers has pointed out, it's sometimes quite difficult if the anatomy is very complex, for example, in the brachial plexus. In this case, you can see there are some nerves which are clearly hyper-intense, and you also have some signal changes in the muscles, and that's very important because you always have to look at both the nerves and the muscles. They are a unit. Especially motoric nerves, they always give you a pathologic muscle signal, and depending on the pattern of the muscle signal, you can go back and identify maybe a nerve lesion. Those guys who do MR Neurography, what's the diagnosis here? Perfect, yes. So there are a lot of experts in this room, actually. So my point is, if you are starting with MR neurography, then you need to first identify the anatomic region at the nerve. And I found it pretty helpful in the beginning to use web tools. So when I teach my residents, I always ask them to open up this web online atlases on the left screen and then to have the PAC system open on the right screen so that they can scroll in parallel through the anatomy, left the textbook, on the right the actual case. And this is very helpful to identify especially smaller nerves, for example in the pelvic region, which, where the nerves are not so obviously and well known by everybody. Then, of course, you need to describe the nerve abnormality the best you can, and I will show you some criteria how you can do that. And then you have, of course, to look for the innervated muscles, because as you have seen in this case with Parsonage-Turner, it gives you a clue of what nerves are involved. And then you have to try to make a diagnosis based on the imaging findings and the clinical information. That's very important because some of these features you can identify on the images, they need interpretation, of course, and if you don't know the clinical information, it is quite hard in MR neurography. It's not like in the knee where you see a meniscal tear and then you're sure it's a meniscal tear. In the nerves, you need a history of the patient. It can completely make a difference if you have a case like this and if it's an acute or chronic stage, for example. So always try to get as much as clinical information as possible, and I like to call my neurologists to ask what they have found in the clinical examination so that I can really match my findings with their findings, and that's the advance of our approach. Then normal versus abnormal nerves, that's sometimes quite tricky actually, especially if you're dealing with these smaller nerves and if you only scan them unilaterally. So sometimes you need really to have both nerves of both sides. If it's a unilateral problem, then you can compare left versus the right-hand side. If you're more experienced, it's easier because you will even identify subtle changes to the nerves, but especially in the beginning, it's quite helpful to have a left versus right comparison. These are 7 criteria. This table was taken from our textbook here about MR neurography, and you can see that there is some criteria you can always apply, like size, the signal intensity of a nerve, the fascicular pattern, the course, the continuity, the perineal fat plane, and the enhancement. And I have heard with great pleasure that Mayo Clinics is also employing a lot of cases with contrast enhancement or contrast. So because I personally like this information, I chose really nicely if there is an ongoing neuritis or pathologic disorder, because there is a good blood-nerve barrier in peripheral nerves, and if this is hampered, it's a very good additional sign of neuropathy. So these are 7 criteria, and if you do your structured reporting, as we do, we always report as much of these criteria in our finding section. Then we also report on the muscles and the vessels. When we give contrast, we usually try to acquire an angiogram as well, for example, in the cervical plexus, so that you can see if there are some vessel abnormalities around the nerves. Sometimes you have an erythema, which compresses the nerve, or some other things you can discover. Then, of course, we try to describe other structures, but to be honest, if we do the shoulder nerves, we're not reporting on the shoulder itself. We always tailor our protocols to the disease we are looking for, so we call it MR neurography of the brachial plexus, maybe of the cervical spine, upper thorax, including the angiogram, but it's not a shoulder MRI. That needs to be known by the clinicians, so it's a tailored protocol. We're not doing randomly exams of the nerves. We tailor our protocol to the nerves, and then we skip most of the other descriptions. So that's it's a standalone examination for the nerves, and that's important to know. And then, as I have said before, it's very important that we give our impression of the case, but we always try to match that with the clinical findings. And be aware that you need to also use the grading systems the clinicians use, like you do it in the shoulder, for example, on slap tears to communicate with your orthopedic surgeons. You also need to know these grading systems your neurologists use, for example, the Seddon and Sunderland grading systems. So be aware that you talk the same language as your clinicians do. And again, I come back to the structure of my talk. This is the red box. I think that is what you can do at home in your daily business. You can do this high-resolution nerve-selective and non-selective imaging, and you can do a good, nice, structured report on those cases. Let's move on to diffusion tensor imaging. It's in the yellow box, which means it's maybe a technique reserved for dedicated centers, maybe not for the outpatient, every outpatient, and it's actually quite complicated to get good images, as you will see. So diffusion tensor imaging is a very good technique for that, and I start always with this slide here. It shows this glass of water. In this glass of water, we have a lot of water protons, and they are actually free to diffuse wherever they want. So this is called a non-restricted diffusion. Then we can put a straw in the glass of water, and all the protons within this straw, they will have a restricted diffusion capability. So they can only go up and down. And this is maybe a representation of this restricted diffusion. And our peripheral nerves are actually very similar to this straw. We have a diffusion which is 3 times higher along a peripheral nerve than across a peripheral nerve. And this diffusion difference between the longitudinal direction and the perpendicular direction, that's what we can employ in MR imaging. So when we acquire an image of a peripheral nerve using diffusion tensor imaging, we always have anisotropic diffusion situation, and that's what we can look for. Diffusion tensor imaging is usually based on an echoplanar imaging sequence, and that is the basic principle of an EPI sequence. You see we have free diffusion here and restricted diffusion. Let's talk about free diffusion. So the sequence starts with a 90-degree excitation pulse. It has an inversion pulse, and then at the end there is the echo readout. In free diffusion, we have an activated or excited proton, but over time it will go out of the imaging plane. So when we do our spin echo readout, we have a decreased signal because most of these excited protons are already gone. In restricted diffusion, those protons, they will stay in plane. At the end, when we do our readout, they will contribute to the signal, so we have an increased signal in restricted diffusion. Quite simple at the end. And you all know that in increased diffusion, low signal, diffusion low, high signal. That's the principle, for example, in DVI of the brain. This is an infarcted area of the brain, and that's restricted diffusion, high signal. The important thing is on diffusion tensor imaging that we do not only get a plus-minus information or 0-1 information, we also get a quantitative information. For example, if we try to look for the diffusion direction, then we have these 3 vectors in all 3 directions of the room, lambda 1, 2, and 3. And these 3 vectors, they describe the main diffusion direction of our protons. Remember the straw we put in the glass. So there are 2 quantitative parameters. One is the FA, the fractional anisotropy. It's a scalar value between 0 and 1, and it actually describes the relationship of these 3 vectors, lambda 1, 2, and 3. So with these 3 vectors, we get the main diffusion direction. And then the second parameter is the ADC, the apparent diffusion coefficient. It's even in the equation of our signal acquisition. You can see in this equation there is also the B value, which you can adjust at your scanners. So quite simple, 2 quantitative parameters which we can derive from our data set. What you know from a couple of talks are these color-coded images. They look pretty nice. The basic principle is that with each main diffusion direction, you assign a color, and then you know that in these red areas, for example, the direction of diffusion is all the same, whereas in the blue areas, the diffusion is in another direction. You could also draw a lot of little arrows for each single voxel. Here, these are all small arrows in this image here. And then you get also information. For example, here you see that the diffusion is all going in the same direction. What you can then do is you can combine these arrows by a line. This is done by software. And then what you end up is actually with a tractography image. So these tractography images are nothing else than combinations of these little arrows, main diffusion directions within the voxels. And sometimes it works very well, like in this red line, but sometimes there are also some disturbed tractography lines, like in this green example here. So it depends a little bit on the software, how well it performs and how good your data set is at the end. So this is a nice image of a tractography image of the brain, of course. But it also works in the peripheral nerves the same. So because sometimes this cannot work very well, you always have to check if the diffusion tracts you get always match actually the anatomy. So here in this case we have an axial T1 sequence, and then we check if the median nerve in this case is really actually matching the diffusion tractography image as well. So always check if what you get from your DTI sequence is really matching the anatomy, because it's not the anatomy, it's a representation of diffusion. The problem with EPI acquisitions is that they tend to need a long acquisition time, but there are possibilities these days to speed up the acquisition. And one of these possibilities is simultaneous multislice imaging, a technique which was developed a couple of years ago, and it actually works quite nicely. For example, we did a study on the median nerve again, and then we had a regular acquisition time of 6 minutes, and we could accelerate it down to 2.5 minutes. Of course, you will lose a little bit of image quality, but as we could show in this study, it's not a problem to speed up the acquisition by 2 or 3-fold the acquisition time. I think we thought it's still a reasonable image quality if you do that. The vendors are actually working on other sequences to combine simultaneous multislice imaging with compressed sensing, and this will bring down the image acquisition time even further. I think we will end up under 2 minutes with a whole data set, for example, of the median nerve using a wrist coil. FA and ADC are very important because a couple of studies have shown that they act as really good indicators for pathology. For example, a study which we did publish in 2012 in radiology showed that we could reach a sensitivity of 83 and a specificity of 67% when we measured a region of interest in the median nerve. We did not look on the retinaculum, we did not look on the nerve size, and we did not look on any other features. We just measured the FA value of that particular nerve at one point in the wrist region. And then we got this sensitivity for diagnosis of carpal tunnel syndrome. That does not look much impressive here, but it's much higher than the clinicians have when they just examine the median nerve by tapping on it, or then when they do the electromyograms. So this is already higher than most of the clinical examinations these days. So we have a pretty strong tool here with measuring FA. FA also acts as a biomarker, and a lot of these rabbits lost their life for these studies. So this is again a study from Japan, and what they did is actually they operated these rabbits and they dissected the sciatic nerve, and then they looked on the recovery of those nerves. And here you can see week 0 up to week 8, the recovery was quite nice, and during the time they measured by MRI the FA value, and this recovery of the nerve correlated very well with a recovery of the FA value. This was actually confirmed by another rabbit study where they used radiation-induced peripheral nerve injury rather than surgical-induced injuries, but at the end, same results, very nice correlation of FA and some other quantitative parameters. And I pulled up a couple of studies. I made a survey last month about where we are these days with DTI. And I would like to summarize at this point of the year that DTI is reliable and maybe clinically useful. Reliable means technically reliable, so it's a very stable technique already if you do it right. And it's also useful if you go for the clinical applications. Here you can see a couple of publications from 2016 showing exactly this. So we have seen that the red box is already ready to go for the clinical routine. We have seen that the yellow box is also ready to go for maybe academic centers or centers which are specialized in MR neurography. And now we will look on some cases to get a good picture of what we can achieve these days. Well, this is a case of a patient who had a motor vehicle accident like a couple of weeks ago, and he was left with these winged scapula. And in these patients, you actually the clinician had the suspicion of injury of the long thoracic nerve. And what we could see that the serratus muscle on the left-hand side looks normal, whereas on the right-hand side, it was actually atrophic. You can isolate these days the nerve on the right-hand side. It was too bright, too thick, and but it was actually in continuity, so it was some kind of a stretch injury, very likely to that nerve. This is another patient, a 34-year-old female. She has 3 kids and known vascular malformation since many years. These are older exams from 2004. And this is an actual exam from 2015, where you can see that the muscular malformation all the way extends from the pelvic region down to the lower leg. And what we did is, because her symptoms worsened, we did an MR Neurography on that patient. Then you can see that this vascular malformation actually follows the sciatic nerve all the way down from the pelvic region. All these bright spots here are vessels rather than nerve structures. Here you can see very small, and then they get enlarged again at the distal thigh. And then here in the knee region, you see that there is a lot of vascular signal around the nerves, and that's really an intraneural vascular malformation in that patient. FA and ADC, I have spoken about these 2 parameters, are actually helpful if you do imaging of tumors. This is a peripheral nerve sheath tumor. You can see we did a DTI study on it. But it's also helpful pre-surgically to actually make DTI images, tractography images, because you can show to the surgeon that actually some fibers are still intact, and it might be helpful to preserve them during surgery rather to really cutting the whole nerve. Another study also shows the value of DTI imaging. This was a patient who had a osteoma and got radiofrequency ablation of this osteoma. The problem was only that the access pathway was right away through the peroneal nerve, which is located here. So the question was basically a forensic question: is the nerve completely destroyed by this pathway or only partially destroyed? So we did a DTI study. You can see here that the tibial nerve is quite normal, but the peroneal nerve actually shows some normal fibers here, but also some very abnormal tractography findings here. And so our diagnosis was that some of the function, not morphology, function of the nerve was preserved, whereas a part of the function was destroyed, and this was actually confirmed by the follow-up of this patient. He did or she did not get operated, but like 3 years ago, 3 years later, she was completely restored to almost normal function. DTI is also helpful in classic symptoms or syndromes such as cubital tunnel syndrome. You can see it here. You always get these bright images of the nerve at the cubital tunnel, and you never know really, is it now pathologic or not? And DTI can help. Here you can see that this part of the cubital, of the ulnar nerve in the cubital tunnel actually shows altered diffusion, not only T2 signal increase, but also altered diffusion, which means that there is altered function. So it might be more pathologic than you would think just by looking on the morphologic images. This is another patient, a 32-year-old patient who had a high voltage accident. So he touched a cable with a lot of current in it. You see all the burns here on the skin. He survived, luckily, but what he was left with a palsy of the right arm, and this is a plexus study, which we did like 2 days later, and you can see there is marked thickening of the brachial nerves on both sides, on the right side more than on the left side, and that's how a high voltage injury to the plexus nerves look like. And I skip this for a reason and this as well, and maybe I go to the last case here. For example, we started to do also imaging of these nerves of the region here in this mandibular, for example. Here you can see a case with a big cyst in the mandibular region, and it's very informative for the surgeons prior to removal of those cysts if the infraalveolar nerve is still intact. And here you can see we did a neurography study of the infraalveolar nerve, which is easily to identify next to that cyst, and it actually made the surgeons using a medial approach rather than a lateral approach for surgery. So we used these techniques in combinations these days for surgical planning as an aid for our surgeons, and they like it quite nicely to discuss those cases preoperatively. So to summarize, you have seen how MR neurography can be applied clinically these days for what FA and ATC might be good, and you have seen some cases to give you an insight into my clinical routine. Thank you very much.